Hello, I'm Mally Shansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to an educational presentation and question and answer with Dr. Mustafa Gündoğar. In our webinar today, we will be discussing a predictable and efficient way to perform minimally invasive endodontics. Before we get started, I'd like to invite viewers to use the question and answer to ask any questions, and they'll be answered at the end of the session as time permits. Now I'm pleased to introduce our speaker. Dr. Mustafa Gündoğar is a graduate of Marmara University, Faculty of Dentistry, where he received his DDS degree in 2005. He attended the Endodontics program of graduate study offered by the Institute of Health Sciences at Marmara University and graduated with a PhD degree in endodontics in 2011. He is currently working in the Department of Endodontics, Faculty of Dentistry at Medipol University in Istanbul, Turkey, as an associated professor since 2020. During that same time, Dr. Gundogar has been working at the Regenerative and Restorative Medicine Research Center. His areas of interest are nickel titanium files, kinematic properties, cyclical torsional resistances of NiTi rotary systems, and the latest trends in endodontic irrigation activation systems. Dr. Gundogar is a renowned speaker and frequently invited to major national and international conferences. He's published more than 50 original research articles in national and international peer-reviewed and indexed journals, and has been working as a reviewer for many indexed international journals. He's an active member of the Turkish Dental Association, Turkish Endodontic Society, and the European Society of Endodontology. Dr. Gündoğar is a social media influencer and is followed by more than 55,000 people on Instagram. He's the founder of Endotalks Library, which is the first patented endodontic educational platform on social media. Thank you so much for joining us, Dr. Gündoğar. We turn the webinar over to you to learn more about today's topic.
Thank you very much for your kind introduction. At first, it's my great honor to be with you here. I would like to thank EndoPractice as family and San Endo family for giving me an opportunity to make a lecture for you. And after the lecture, if you have any questions, you can reach me easily by my Instagram account. I'm regularly using it, and I can answer all your questions if you try to follow me on Instagram. At first, I want to show you my beautiful city, Istanbul. I am living in this great city. This is the Bosphorus that connects the European side and the Asian side of two big continents. And nowadays, more than 25 million people are living in this great city. And I advise you to visit Istanbul for the once in your life. Today, I want to start my lecture by talking about Instagram and Facebook dentistry because over a past decade, more than 20% of the published articles in specialty endodontic journals have been inspired by the dentists on Instagram or Facebook, because we are seeing many cases that posted by dentists and the endodontists. And they always say that, look, how small my endodontic access cavity, or they usually share postings like, look, how radiographically beautiful my root canal treatment in spite of such a little endodontic access cavity. We are seeing many cases like this on social media, but we should mainly focus on to treat and prevent of apical periodontitis, because apical periodontitis is a very common disease around the world. And when we check the literature, we will see that half of the adult population worldwide have at least one tooth with apical periodontitis. And root canal disinfection is the major weapon when we are fighting against apical periodontitis. And we know that we have some key challenges in endodontic treatment. One of these key challenges is anatomical challenges, and the other is microbiological challenges. But when we check the literature starting from this article, we will see that a great number of the endodontically treated teeth were extracted due to the coronal fractures, unrestorable coronal fractures, and radicular fractures. So we have one more common key challenge in endodontic treatment, and it is structural integrity. And when we primarily focus on treating and preventing the apical periodontitis, we usually forget how to survive the teeth in our patient's mouth. We usually focus on which file I should use, how many files should I use, or which sealer do I have to use to obturate the root canals. But everything means nothing if the tooth is not in the mouth anymore. So one of our other primary outcome should be the survival of the endodontically treated teeth. So we should focus on preserving more dentin when we are performing our root canal treatments. And thanks to Anil Kishan amazing article, we know that endodontically treated teeth were usually fractured by many reasons like physiological, pathological, and iatrogenic reasons. So what is minimal invasive and what are minimal invasive procedures? Minimal invasive is a technical goal and a realistic aim. Our first aim when we are using minimal invasive endodontic procedures or minimal invasive procedures, we should not damage the surrounding tissues when we are performing our procedures. This is very important for us. And when we have chance to have minimal invasive procedures on our bodies, we of course usually prefer minimal invasive techniques. When we are having knee surgeries, appendectomies, liver surgeries, we never say no when the doctor prefers and advise us to get minimal invasive procedures on our bodies. What about in dentistry? The first term of minimal invasive dentistry was described by Dan Erickson. He taught that minimal invasive dentistry includes a systematic respect for original tissues during the prevention or treatment of dental diseases. However, respect for dental tissue cannot become more important than the treatment of the disease. This description is really very important to us. What about for endodontics? What about minimal invasive endodontics? When we say minimal invasive endodontic approach, some dentists and endodontists are really skeptical about this issue and this topic. So, is minimal invasive endodontics a fad? Before starting that, we should focus on literature about minimal invasive endodontics. And before we start checking the literature, we should focus on access cavity designs, preparation size, and the irrigation techniques when we are comparing minimal invasive endodontic procedures with the traditional ones. But at first, we should understand the dentin. And again, thanks to Anil Kishan, amazing article, Biomechanics of Fractures in Endodontically Treated Teeth, we all know that dentin is a composite material. It consists of inorganic part, organic part, and water. And each this part has a role to play. And each these parts makes the dentin a viscoelastic material. So when we read the articles, when we search for the fractures patterns of endodontically treated teeth, we should read these articles very carefully. Because most of the articles classifying the minimal invasive endodontic access cavities or the fracture strand of the access cavities, most of the studies are using load the fracture tests or loaded fracture tests. When we check the literature, we cannot find fracture assistant tests. Fracture toughness means fracture assistance that includes crack propagation. But in many of the articles that compare minimal invasive endodontic access cavities, we don't see fracture assistant tests. And many articles perform their material and methods parts by using static loading tests. But we should focus on more cycling loading tests, because we know that when an endodontically treated tooth is broken in the mouth, it's not usually because of an instant force. The tooth that's endodontically treated is usually fractured due to the multiple functional loading. And we all know from the material science that 19% of the fractures are attributed to cycling loading. This is very important to understand the material method parts of these fracture tests, because now we are going to see many articles from the literatures, and we will see that there is no established standards on these articles. What about cumulative effects? Thanks to this great picture by Zabata, we know that biofilms cause a reduction in fatigue resistance. So we should know that the tooth has already lost its strength when we start treatment. So cumulative effects are really important for us. On the other hand, we know that the sequence of sodium hypochlorite and EDTA have detrimental effects on root canal dentin walls. And we should also account for the environmental effects when we started to treat the teeth as endodontically treated teeth, because the corrosive effects have also a detrimental effect on the root canal dentin walls. So what are the notes to consider before checking the literature? Structural failures are not understood very well. Static tests do not account for vast majority of structural failures. Testing methods influence our clinical decisions. These statements is really very correct, because we are mainly focusing on our cases when we read these articles, and we always share our cases on Instagram and Facebook Dentistry. And we should also account for cumulative effects. And I prefer saying conservative endodontics rather than saying minimal invasive endodontics, because people are not so much skeptical when I say conservative endodontics instead of saying minimal invasive endodontics. So what are the most minimally invasive endodontic procedures? We know that the most minimally invasive endodontic procedure is vital pulp therapy. In this therapy, we are protecting the pulp, and we are making it live during the survival of the tooth. But this is not the subject of today. On the other hand, there are many ways of making minimal invasive endodontic procedures rather than cutting dentins. And this is a great case by incredible endodontist Dr. Bakkanen. And in here, he's not doing a normal endodontic root canal treatment by gaining an excess cavity. In here, he's directly making a retrograde procedures, apical surgery, and protecting more dentin. This is also a minimal invasive endodontics way. In fact, the minimal invasive endodontics started with this famous article by Kademe and Clark. In their article, they introduced us a new model for gaining an access to the root canal walls when we are opening our excess cavities. And they concluded that preserving pericervical dentin area, which is about 4 millimeters above the root canal orifice, above and under the 4 millimeters. This is pericervical dentin area, and they claimed that protecting pericervical dentin will increase the strength of endodontically treated teeth. And we all know that pericervical dentin is the area that transmits the occlusal forces to the root canal walls and the root canal dentin and the root of the tooth. So we should preserve pericervical dentin when we are shaping our root canals and when we are opening our access cavities. Then, is there an optimal access cavity design for minimal invasive endodontics? Let's check the literature. When we check the articles about minimal invasive endodontic access cavities, we will see that there is no an established standards when we read the material and the methods parts. And most of these studies used static loading tests. And in most of the studies, the teeth were not restorated, the root canals were not filled or filled with obturation techniques. But as I mentioned at the beginning of my presentation, we should focus on cycling loading tests. And there are some methodological evaluation in terms of performing these tests. And there is a limited number of studies in the literature using cyclic loading tests. And with these articles using cyclic loading tests that they use a chewing stimulator, they again couldn't find any differences on the strength of endodontically treated teeth with minimal invasive access cavities and traditional access cavities, because on those articles they compared it with conservative endodontic access cavities, traditional endodontic access cavities, ninja access cavities, truss endodontic access cavities, but we still don't know what the conservative endodontic access cavity is, traditional endodontic access cavities, or ninja access cavities. They are opening a small access cavity, but we don't know how small it is. But when we also read the articles using cyclic loading tests, we again couldn't find any differences between traditional access cavities and minimally invasive endodontic access cavities. But in this recently published article by Selakumer et al., they again found a no significant difference between traditional endodontic access cavity and a conservative access cavity, but they showed that number of the unrestorable fractures were more common in traditional endodontic access cavities. So according to this article, it's not really bad to open a minimal invasive endodontic access cavity. And when we check the literature reviews about minimally invasive endodontic access cavities, we are going to see that there is no, again, an established standards in these articles. Some of the articles tell that minimal invasive endodontic access cavities are not bad, and some review articles tell that minimal invasive endodontic access cavities are bad. And this recently published Regenerative review also concluded that minimal invasive endodontic access cavities may not be bad for our endodontic treatments. So when we check and when we conclude the scientific evidence-based summary about minimally invasive endodontic cavities and the traditional access cavities, we will see that access cavity size does not affect the instrument fractures. The volume of dentin and the fracture strength likely depend on tooth type. And we will see that some small access cavities improve fracture strength than the larger ones, larger accesses, and some do not improve. So, which access cavity is the best? Clinically relevant conclusion is almost impossible about that, because dentin biomechanics, as I mentioned at the beginning of my lecture, is not easy to understand. There are different loading types in the literatures. There are different loading angles when we are performing these tests. And as I told before, the cavities with filling and without filling in some studies, and the canals are obturated and non-obturated in some articles. So clinically relevant conclusion is almost impossible. So, is it necessary to classify these access cavities like traditional access cavity, conservative access cavity, ultra conservative access cavity, truss access cavity, or ninja access cavity? In my opinion, we don't need to do that, because we should know that our access cavities are dynamic access cavities, should be dynamic, and they really these access cavities as case demands, because when we are treating our patients, we don't have virgin teeth. Most of the teeth have cavities. Most of the teeth have cavities on the mesial part of the tooth, distal part of the tooth. So we don't have virgin access cavities. So dentin preservation should be our first aim when we are opening our access cavities. And protecting pericervical dentin area is another important issue when we are opening our endodontic access cavities. Look at this teeth that we are going to treat and we are going to perform endodontic treatment. We cannot open a traditional or a minimal invasive access cavities in this tooth, because these are not virgin. At first, we are going to clean this decay, and we should focus on preserving much dentin. Look at our access cavity done by my friend Mustafa in Iraq. You see the access cavity? In here, we are cleaning the decay. We are seeing our root canal orifices, and in here, we are protecting the marginal ridge here. So I'm 100% sure that this tooth will get much more strength than the traditional access cavities when I compare these two access cavity designs. What about the debridement from the root canals when we are opening a traditional access cavity and a minimal invasive access cavity? Nicoletan's group is the first that searched this issue. They opened the traditional access cavity, as you see here, and they opened the truss access cavity, and they searched the root canal debridement between these two access cavities. And as a result, they showed that the tissue remains inside the truss access cavity is much more than the traditional access cavity. But when they checked the root canals and the root canal walls, they found no significant difference between a traditional access cavity and the truss access cavity. And in here, they only used shearing edge irrigation. So we can understand from this article that if we open a small access cavity and if we use advanced irrigation activation methods, we can really have clean root canal walls, and we don't need to open big access cavities. And they showed these findings by using histological sections. And we check the literature when we are talking about minimally invasive access cavities. What about shaping procedures? What should be our final apical size when we want to do minimally invasive endodontics? Or what taper should I finish my root canal treatments? Let's check this issue. In fact, the Pandora's box is opened by the Schmitz et al.'s articles, because in this article they showed that shaping procedures when we are using nickel titanium files or some another traditional files, we can have some micro cracks on the root canal dentin walls. And they showed opposite to this article, thanks to cadaver studies from Gustavo Deus and Versiani studies and this study, we can conclude that nickel titanium rotary files or reciprocating files will not cause any micro cracks on the root canal dentin walls. And we know that from these articles, the number of the dentinal microcracks has no correlation with the force required to fracture extracted teeth. No dentical microcrack is observed neither in the baseline image nor after root canal preparation in fresh cadaver monoblocks. So this issue is closed. Nickel titanium instrumentation files will not cause any microcracks on root canal dentinal walls. What about shaping procedures? What will happen to endodontically treated tooth when we increase the shaping size? Kishan et al. Is the first group that searched this issue, and they found that when you increase the size of the root canal from ISO 20 to ISO 50, they showed a fracture incidence, and they showed that the fracture strength of the endodontically treated teeth will decrease when you increase the size of the root canals. And another interesting article by Platino and Zogeb showed that smaller tapers were directly related to more favorable and repairable registrate fractures than the larger ones. And this great article from Heberer et al. Showed that by using cyclic loading tests, by using jamming stimulators, they showed that instruments with greater taper for root canal instrumentation should be used with care to avoid negative long-term effects in form of propagation of dentinal defects over time. So using small taper instruments and using small shaping size will increase the strength of endodontically treated teeth. But what do we know about the shaping procedures when we are using our irrigation procedures? We were all taught that the irrigation needle or the tip of the irrigation needle should be as close as to the apical part of the root canal, maybe 1 or 2 millimeters away from 1 or 2 millimeters below from the working length. But can the root canals be cleaned without removing too much dentin? If we use minimal preparation techniques, it's impossible for us to touch the all root canal wall dentin. What will happen to these areas? What about maximum preparation when we touch the all root canal wall, ideally? Of course, if we prepare our shaping procedures like that, we are going to destroy the root canal wall dentin, and maybe we are going to lead to vertical root fractures if we make so big root canal shaping size. And we all know from the literature and the microcity studies that root canal anatomy is much more complex than we think. And a high percentage of the root canal wall were untouched when we are using our nickel files. You can use the most famous nickel titanium file in the dental industry. You can use the most advanced endodontic motor. It is impossible for you to clean all the root canal walls. There will be always a mechanical debridement deficit. So irrigation procedures, giving energy to sodium hypochlorite, is much more important than instrumentation techniques. And thanks to this great article by Secure et al., we know that a high amount of the root canal walls, a high percentage of the root canal walls will remain untouched when we are using our instrumentation techniques. Even when we use a 40 size reciproc file, 34.6% of the walls will be untouched. This is a very huge amount. And these untouched walls will include many microorganisms. But if we read this article carefully, we will see that the authors used only shearing edge irrigation. They didn't use any advanced irrigation methods as we have in the dental market today. And do you think that the results would be different if the authors used different irrigation activation methods? I'm 100% that the results will change. And When we check the literature again, a very good article by Martin Trop's team, they showed that when they increased the size of the root canal, they showed a more microbial reduction from the root canals. Opposite to this article, Caldero et al. Showed that it will not be necessary to remove dentin in the apical part of the root canal when a suitable coronal taper is achieved to allow satisfactory irrigation of the root canal system with antimicrobial agents. So these two articles have conflicting results about the apical enlargement of the root canals. And Kademi et al. Showed that 30 size will be enough to have clean root canal walls. And we usually recommend 3004 to GPs and endodontists to make their final size. But in this study, they used scanning electron microscopic methods, and we all know that scanning electron microscopy techniques are not the best techniques to show if the root canal dentin tubules or the root canal walls are clean or not. So we need more studies about this issue. And when we read these two great reviews by Aminashire et al., they showed that having larger apical sizes will have more predictable healing outcomes and more predictable microbacterial reduction. But if you read this article carefully, you will see that the many authors used only shrinkage irrigation. Again, they didn't use any irrigation activation methods. And thanks to these great images by Zabata, they showed that 2% chlorhexidine does not dissolve biofilms. 30 minutes of sodium hypochlorite are necessary to have higher volumes of biofilm solution and to increase the cleaning of dentin independently of the concentration in comparison with the 5-minute and the 15-minute contact times. So the most important thing for us when we are using irrigation procedures is irrigant delivery and irrigant activation. What about the vital bulbs? Does apical size matter in the case of vital bulbs? Again, a great article by the Nicoletan's group showed that 2004 will be enough to clean the root canal walls of the dentin if we are using passive ultrasonic activation. But don't forget, in vital bulbs, if you don't use passive ultrasonic irrigation, you have to enlarge the root canals until 4004. Because we all know that when we open the excess cavity of a vital pulp under rubber dam, we know that the pulp is not inflamed. So using an effective irrigation activation method will be enough to clean the root canal walls. So you don't have to get big root canal sizes or big root canal tapers to clean the root canal walls of such vital pulp teeth. What about increasing the size of the root canal walls in the terms of accumulated hard tissue debris? We all know from the literature that if we increase the size of the root canals, we are going to pack more accumulated hard tissue thin debris into the non-instrumentated areas or difficult to instrument areas like isthmuses or lateral canals or apical ramification size. So it will be much better to shape the root canals to a not big canal size shapes, and to use irrigation activation methods will be much better for us to have more predictable results. Then, is it possible to disinfect the root canal space without removing too much tooth structure? Or is it possible to have minimal sizes when we are treating or preventing apical periodontitis? The instrumentation can remove a great part of the septic content from the root canal. But as I mentioned before, no file system will ever disinfect the root canal. Again, I am repeating it. You can use the most advanced NITE file in the dental industry. You can use the most advanced endomotor in the dental industry, in the dental market. But it will be impossible for you to clean the root canal walls. In today's endodontics, in my opinion, a file matters not at all. Irrigation and the activation of the irrigation solutions is important. Giving enough amount of energy to sodium hypochlorite is important for us because we have biofilm layers on infected root canal walls. And it's really not easy to remove this biofilm layer by using only shrink edge irrigation, sonic agitation techniques, ultrasonic activation methods, lasers. It's not, or GentleWave. It's not really easy to remove biofilm layers from the root canal walls. And we all know that these biofilm layers are hidden inside the untouchable areas like isthmuses and lateral canals and the apical part of the root canal, which is really important for us to disinfect, to clean, to prevent and heal of the apical periodontitis. Intraradicular biofilm is found in a high percentage of amount in the apical part of the root canals. And from an amazing study from Secure et al., we all know that the most important part to have a really very predictable success in endodontically treated teeth is to clean and disinfect the apical root canal system, not the coronal and the middle. In the dental world, all the dentists and the endodontists are cleaning and disinfecting very well to the coronal and the middle parts of the root canal wall. But we are having difficulties to clean and disinfect the apical root canal systems because we don't know how to give amount of energy to the apical part of the root canals. And in a study newly published by Zender, they showed that, this article is very important, they showed that ultrasonic irrigation improved the disinfection of the root canals after chemomechanical procedures by reducing bacterial levels. However, persisting bacteria remained active in the root canals after chemomechanical procedures and ultrasonic irrigation. So you may assume that you are cleaning and disinfecting your root canal walls by using passive ultrasonic irrigation or passive ultrasonic activation methods, but you should keep in your mind that there might be still persistent bacteria remained active inside your root canals. And what is the influence of apical preparation size and irrigation type on bacterial reduction in root canal treated teeth with apical periodontitis? We all know that irrespective of the type of irrigant, an increase in the apical preparation size significantly enhanced root canal disinfection. But in this article, again, the authors didn't use irrigant activation systems. They only use shrink edge irrigation. But again, in our study published by me and by our Italian friends, Grande and Platino, we showed that increasing the size of the root canal walls will be much more better to clean the root canal dentinal walls. However, the taper will have no impact on the root canal cleanness. So increasing the size of the root canal walls will enable us to have much more root canal clean walls by using sonic agitation systems, but root canal taper will not have an impact on the cleanness of root canal walls. And again, an article, a systematic review and a meta-analysis published in 2004, when I compare it with 2005 by Emisher et al., they all showed that having root canal size more than 30 will improve healing outcomes. But all these articles have a low certainty evidence. And we need more clinical studies about this issue of having a big preparation size or small preparation size. And another interesting article, Azim et al., a Tennessee study, showed that having apical preparation size under 35 will not have predictable healing outcomes. But again, I advise you to read these articles carefully. When you read these articles carefully, you are going to see that shaping the root canals until 25 will delay the apical healing 1 month. And in my opinion, 1 month will mean nothing because it's not a long time in the healing of apical periodontitis or apical lesions. What about non-instrumentation endo when we are using it in the healing and the prevention of apical periodontitis? Do you think that will it be okay to clean all the root canal walls without using any file or endomotor? In fact, Lucy et al. Showed that in 1990, and she showed that it is possible to clean a root canal system by a non-instrumentation technique. But in 1993, and the technology in that times did not let Lucy et al. To develop a machine to clean the root canal system by a non-instrumenting technique. But after many years of this study, Hapasulo's team showed that it is really possible to have clean root canal walls without using any files. With a non-instrumentation cleaning technique like multisonic activation techniques, multisonic systems, you can have a really clean root canal walls without a file. So, when science and technology meets together, things will change. So technology and science are really very important in the developments and endodontics, and we will see many advanced developments in the near future. GentleWave system. GentleWave system is a really very great system and maybe a game changer in endo world. At first, the GentleWave G3 system was introduced in the dental market, but later they developed this system and they launched GentleWave G4 system. And believe me that when you go to a dental congress or an endodontic congress around the world, apart from United States, you will see many endodontists and dentists discussing about GentleWave technology. They are always talking about each other if this technology really works. And is it possible to clean all the root canal walls without using any files or using just a few files? Everyone is discussing about this issue. And Sanendo claims that as endodontists, our world is changing. What is GentleWave procedures, or what are the advantages of GentleWave procedures? Let's talk about that. Firstly, GentleWave procedures use multisonic energy. And GentleWave use negative apical pressure techniques. This is very important because you don't have the risk of extrusion of sodium hypochlorite or any sodium hypochlorite when you are using GentleWave procedures. And also, GentleWave procedures enables you to do minimal instrumentation techniques when you are performing your root canal treatments. What is our success when we are treating our patients? We primarily perform our endodontic treatment. When we are unsuccessful at our primary endodontic treatment, we perform non-surgical retreatment. If we are again unsuccessful, we are doing apical surgeries. Wouldn't it be great if the primary conventional endodontic treatment would have a highly predictable positive outcome? So the main aim of Sanendo and the main aim of GentleWave technology is to treat patients in a more predictable way. The patient's outcomes are really very important for Sanendo and GentleWave. Change is the only constant. And in my opinion, GentleWave is a game changer in endo world. And I don't advise you to name GentleWave as an irrigation device because GentleWave is a methodology, is a technique, is a procedures. Because in GentleWave, it will be enough for you to use just the patency file and the glide path file to finish all your instrumentation procedures. The real minimal instrumentation technique will be enough for you when you are using this device. And in these procedures, in GentleWave, you don't need shearing edge irrigation anymore. And clean flow procedure instrument is an innovative technology, and this clean flow procedure instrument is the only device in the dental market that cleans the tooth from the outside. And thanks to my dear doctors, Dr. Wendy and Dr. Kirk, they taught me how to use GentleWave device. And I was really surprised for the first time when I'm using this technology. When I hear the sound of this device, I was really amazed because I really felt the power of multisonic energy. Look at this sound. Incredible.
See that noise? That is.
And when you are using GentleWave after opening an excess cavity, you should have to make a build up on the excess cavity to place the clean flow procedure instrument. And some dentists assume that
You'll have your
it's
favorites.
not easy to make a platform, a build-up platform on the excess cavity, but believe me that when you try it 1 or 2 times, it will be really very easy for you to make a build-up before placing clean flow procedure instruments on your root canal treatments. And you are just using like a rubber dam liquid material when you are making your build-up procedures. And you will also make a build-up when you are using this clean flows matrix device.
That off, and I like to see how
So,
And it will be very easy
place it.
to make a
And one of the tricks I
platform
learned
by
to
using
get to
this
use
incredible
is when you place it,
material.
push it down and then just rotate it. But so now you have to alleviate any surface.
This is the platform before placing clean flow instrument. And let me share some of the cases that I tried to see during my observation time in Dr. Karen Potter's clinic. This is an upper right second molar tooth with calcified canals. The patient is 83 years old, and it's really very difficult to negotiate all the root canals until the apex. And Dr. Karen Potter started
It basically
Making
helps
the build-up after gaining
rotate
access
the platform.
the
on
root
the
canal
tooth,
wall
But also just the dry field helps retain it.
before using
I
GentleWave.
do a thin layer of the occlusal table, just so that I have enough sound seal to cover my tooth. I try in my matrix, and it's seated all the way. So sometimes it doesn't. If it only seats to here, I have to build sound seal up. But because my matrix seats, I'm ready to load the matrix. See?
Garcia here also, she is putting the materials on the matrix.
So I've got to pop my bubble.
There should be no bubbles when you are making these build-up procedures. And at the end, she has a platform like that on the tooth. And after that, our incredible device, GentleWave, starts to work. 8 minutes will be enough to clean and disinfect the root canal wall. And this is a really very revolution in endodontics because Dr. Karen Potter is just holding the clean flow device while she's performing her root canal treatment. No file anymore, no endomotor after gaining access to the root canals, just using this instrument. And can you see the flash of sodium hypochlorite and EDTA, there is a continuous flow inside the root canals following sodium hypochlorite, distilled water, and EDTA. And after finishing the GentleWave procedures, she is operating the root canals with only one gutta percha and bioceramic root canal sealers. This is the first radiograph from the patient, and with an angulation size, you may see that MB1, MB2, palatinal and the distal canals are okay by using GentleWave device and by using only one file with minimal instrumentation. And this is the article with the cases of Karen Potter's that's published in End of Practice as in last issue. You may read our cases and you may see our cases in that great article. For example, this is the central incisor with a calcified canal that we just used only one file. We operate the root canals by using GentleWave procedure. We just use GentleWave device. You see just after the operation, and 1 year later, you can see that healing is completed. Amazing. And there's also an interesting case. You see the apical lesion here, just with minimal instrumentation and by using GentleWave procedures. This is after the GentleWave procedures. You see how the root canals are operated and shaped respect to the root canal anatomy just after root canal operation. And 6 months later, the apical lesion is healed. Incredible periapical healing. As Dr. Kirk Curry said in his lectures, endodontics reimagined by using GentleWave procedures. And when we see the cases of GentleWave on the social media, the root canal operations are really very different that we are used to do before. Because when you are using GentleWave, you are seeing that all the root canal anatomy, Hess anatomy, is operated with your bioceramic root canal sealers because of the highest cleaning performance of GentleWave. And this is the first GentleWave case of Dr. Kirk Curry in 2018, just after the procedures. And he shared it on EAE last Congress. 6 years later, the root canal seems really very well. And at the last Congress of TDA software, Endocon, the GentleWave users started to see the new software of GentleWave. And in this new software, you can adjust the concentration of sodium hypochlorite between 5% and 1%. And when you want to use it in calcified canals, you can adjust the concentration of sodium hypochlorite, as you
typically
see here.
3% sodium hypochlorite. Whatever concentration level you choose for that particular.
And also with this new software, you can see many videos before started to use GentleWave, like the experience of the patients.
Series of videos that actually do patient education in office. So the team can roll this machine in and then educate the patient on site about
So technology never stops in Sanendo, and they are still trying to improve GentleWave procedures. This is also very, now I will share some interesting cases by Dr. Habas. This is a young patient with a huge caries. They tried to stop the bleeding, but they couldn't stop the bleeding. So instead of having a vital pulp therapy, they start root canal treatment by using GentleWave procedures. This is the image of mesial root canal walls after GentleWave. And this is the distal canal walls after GentleWave. You see how the apical third of the root canal is cleaned by using GentleWave technology. And this is just after the operation. And there's an interesting canine case. You see here, there is a broken filling, just gaining an minimal invasive access cavity. And by using GentleWave procedures, you see how the lateral canal, like an S-shaped lateral canal, is cleaned and filled with using GentleWave technology. And this again in dense case. You see the apical lesion here. It's really very difficult to instrument these root canals. The patient has an apical abscess. By using, you see the necrotic dens, by using GentleWave procedures and operating with bioceramic root canal sealers, you can see the root canal anatomy and you can see how it is cleaned and obturated. Amazing healing. So GentleWave procedure really works. And when we check the literature, there are more than 40 articles published in very important endodontic journals showing the benefits of GentleWave and showing the GentleWave really works inside the root canals. And many articles, when you see from a very important endodontist, we will see and we will check that GentleWave really works in the root canals very well and cleans the root canal walls very well in spite of having minimal instrumentation techniques. And this is the last article from Bettina Basrani. They again used no files and they showed that the use of GentleWave on non-instrumented root canal system could be an effective disinfection protocol, removing the biofilm without dentin debris formation. And this is also a very important article. I advise you to read. And also, what about apical healing cases? Shigerson et al. Showed that by using maximum shape size 20, they showed nearly an 100% healing rates by using GentleWave. What about laser assistant activation? What about erbium YAG laser or erbium chromium YSGG laser? In the dental market, you may see photono devices as erbium YAG lasers, pips and sweeps technology, waterless from BioLase, and H-Pro. These are the lasers used in endodontics, especially for the activation of the root canal irrigants. The photono use erbium YAG lasers and the BioLase use erbium chromium YSGG lasers. But when we check the literature and when we compare the erbium YAG lasers with GentleWave, in photonas, sweeps, and pips technology, there is a shock pulse, there is a positive pressure, there is no negative apical pressure in lasers, so you may have the risk of extrusion of sodium hypochlorite. There is no sodium hypochlorite circulation tip in the pulp chamber. So when you are using sweeps and pips, no canal wall ablation. The instructions for clinical use show variation. Research indicates that YAG lasers is better than YSGC lasers, but there are positive users' comments. What about erbium chromium YSGG lasers? There is again no shock pulse. There is positive pressure. There is no sodium hypochlorite circulation. But when you are using erbium chromium YSGG lasers in waterlase and H-Pro, you are placing the laser tip inside the root canals. So there could be always risk of root canal dentin wall ablation. Again, in these lasers, there is no instruction for clinical use, research support limited, and maybe weaker than erbium YAG lasers, but there are also positive user comments when you search on social media. And as I mentioned, when you place the fiber tip inside the root canals with BioLase lasers, when you place the laser tip inside the root canals, there can be an ablation of the root canal walls. Now, let me share you some videos comparing lasers and the GentleWave. For example, this is Photonas pips and sweeps technology. When you are using this technology as a root canal irrigation activation system, there is always a positive pressure, no negative apical pressure, and there is always a risk of extrusion of irrigant. What about BioLase? In BioLase, you are also placing the tip inside the root canals, as you see here. And when you start to activate the root canal irrigant, there is also a risk of apical extrusion of irrigant. Also, in H-Pro, you are placing the fiber tip inside the root canals. And when you start to activate, there is a risk of apical extrusion. And sometimes patients may not feel it. But if you use GentleWave, especially when we enlarge the root canals and when we compare it with shrinkage irrigation or the other lasers, there is no risk of sodium hypochlorite extrusion or any irrigant irrigation because GentleWave systems uses negative apical pressure techniques when I compared it with the lasers or with any other irrigation activations like passive or sonic activation methods. Even when you use a shearing edge irrigation, there is always a risk of apical extrusion of sodium hypochlorite. And also, an article published me and my group showed that laser activated irrigation systems may provide postoperative pain on the patients. And this very important article published by me and my group showed that there is no significant difference in the microbial reduction inside the root canals when we use passive ultrasonic irrigation and laser activated irrigation. So we need more clinical studies to show that this system is better than the other system, or this irrigation activation system is working better than the other irrigation activation systems when we are comparing these high-tech devices. So we should choose our side when we want to buy a high technological devices. Which one should I use? Lasers or GentleWave? When we check the literature, we will see that if you want to use minimal invasive endodontic methods, if you want to use minimal invasive endodontic procedures, and if you want to perform a safe activation, this is very important. If you don't want to extrude your sodium hypochlorite, if you want a safe activation, the literature shows that GentleWave is really better than the other irrigation activation devices, and especially when I compare it with the lasers. So where are we now at endodontics? We are now in endodontics with minimal mechanical shaping, preserve more dentin. This is important. Irrigation, not for just main canal, but we should also irrigate and clean the isthmuses and the lateral canals. So some irrigation activation methods may not be enough for us for the cleaning and the disinfecting of the isthmuses, lateral canals, and the apical ramification. And we should not obturate. We should not obturate only the main canal, but we should also try to clean and obturate the isthmuses, lateral canals, and the ramifications. So in that part of the endodontics, the technology will help us to do all these procedures in a minimal invasive way. And in my opinion, in the next years, the technology will be a game changer in endodontics, and the devices like GentleWave will be a game changer. Thank you very much for listening to me, and I would like to thank again Sun Endo family and the Endo Practice as family for giving me a chance to meet with you in this great webinar. Thank you very much for listening to me, and you can follow me by using my Instagram account, Endo Mustafa Gündoğar. I have many followers, and I am actively using my Instagram account. You can ask any question about endodontics by being in contact with this account. Bye-bye. Have a nice day. See you later.
Well, thank you, Dr. Gundogar. There are some questions coming in, but before I get to those, I would like again to invite viewers to use the question and answer feature in the control panel on your screen to ask any questions. We do have a question for you, some questions. Can you elaborate on the findings between sodium hypochlorite versus EDTA versus sodium hypochlorite and HEDP on the collagen surface?
Yes, when we check the literature, we have scientific clinical evidence that a sequence of sodium hypochlorite and EDTA and sodium hypochlorite may have detrimental effects on the root canal dentin walls. Especially Zender et al. And Nicolatan et al. Showed that using HEDP with sodium hypochlorite will not cause any detrimental effects on root canal dentin walls. So reducing the time of sodium hypochlorite, when you are using it in combination of with EDTA, will have less detrimental effects on the root canal dentinal walls. So using HEDP will be more useful for us.
Okay, another question. Which laser worked better, the YAG or YSGG?
Which laser, sorry?
Which laser worked better, the YAG or the YSGG?
When we check the literature, especially when we ask the users these two lasers, they don't find any difference between them. But in my opinion, with using Photona's erbium YAG laser, you are placing the laser tip inside the excess cavity, not inside in the root canal walls, in the root canal dentin walls. You are not placing the fiber tip inside the root canals. But with you are using erbium chromium YSGG lasers, you are placing the tip inside the root canals, and there may be a risk of root canal dentinal wall ablation. So this will be a very bad effect for the patients. In my opinion, YAG laser is safer than erbium chromium YSGG lasers, and the literature also showed that.
Okay, how does GentleWave compare to laser for debridement?
In fact, we don't have so much data when we are comparing lasers and GentleWaves. We should have much more clinical trials about that. But when we are using GentleWave, there is an amount of scientific evidence-based information in the literature that you don't have to use any file or endomotor when you are using GentleWave, because Basrani et al. And Hapasula et al. Showed that when you are using GentleWave, you may have really very root canal walls. But when I compare it with lasers, there is no data showing that using non-instrumentation technique when you are using erbium chromium YSGG laser or erbium YAG laser. So GentleWave may work really much better than the lasers when we check the literature.
Okay, you talked about using lasers and then the GentleWave. Which one was easier?
In my opinion, GentleWave is much easier than using lasers because there is no clear instruction for laser users. For example, in erbium YAG lasers, you are placing the fiber tip inside the excess cavity, but we don't know how long should we should be close to root canal orifice. There is no clear instruction in that. For erbium chromium YSGG lasers, we are placing the tip inside the root canals, but we still don't know how close should we be to the apical area of the root canal walls. There is no clinical instruction. When you ask this to a laser users, he is using a different technique. When the other laser users, when I ask some questions about how you are using these fiber tips, they are telling me different techniques. When we check the literature, there is no clinical instruction. But for GentleWave, there is a clear instruction. You are just opening your excess cavity. You are localizing the root canal orifice. You are just estimating the working length. You are making a build up and just placing clean flow on this build up and just starting GentleWave multisonic energy in 8 minutes time. This is a clear instruction. But with lasers, there is no clinical instruction, and also literature shows that.
Okay, and our last question, you cited a success rate of 97.7% at 12 months in one of your studies. Did lasers have a comparable success rate?
This is not my study. This is the study done by Sujerkan et al. And there is no study in the literature showing such a rapid healing rate when using lasers.
Okay, well, thank you. Thank you everyone for your questions, but we've run out of time today. If we did not get to your question, we will answer it after the webinar via email. Within 1 hour, all registrants will be emailed a link to the replay and continuing education quiz to complete for the certificate. Thank you all again for attending, and a special thank you to Dr. Mustafa Gündoğar and our sponsor for this webinar, Sun Endo. Thank you and be well.
Bye-bye. Thank you.